Welcome to this explainer on the critical surgical competencies surrounding shock, hemorrhage, and resuscitation. Now, as final year MBBS students, you already know the basics. So today, we're not just going to recite the raw pathophysiology of tissue hypoperfusion. Instead, we're going to translate that into real, life-saving clinical action. We'll also be looking at how modern medicine is actively integrating artificial intelligence for early detection, and crucially, how we navigate communicating these truly terrifying moments to our patients and their families with profound empathy.
Our clinical pathway today covers 5 key steps: defining the shock state, classification of shock, recognizing clinical features, principles of resuscitation, and finally, damage control resuscitation. Let's dive right in.
All right, Section 1, defining the shock state. Let's start with the foundational biological reality of what's actually happening at the cellular level.
So, regardless of the initiator, whether it's a massive hemorrhage, a failing heart, or overwhelming sepsis, shock is fundamentally a state of systemic tissue hypoperfusion. The tissues are quite literally starving for oxygen. Because of this, the cells are forced into anaerobic respiration and they start pumping out lactic acid. If you don't resuscitate this quickly, this cellular ischemia triggers local inflammation that eventually flushes right into the systemic circulation. This leads directly to reperfusion injury, and ultimately, the whole system crashes into multiple organ failure.
Now, here is a golden rule you absolutely must carry with you on the wards. Hypovolemia is by far the most common form of shock. And honestly, to some degree, it's a component of almost all other forms too. Absolute or relative hypovolemia has to be excluded or treated in every single shocked patient you encounter. If you administer inotropic or chronotropic agents to an empty heart, you will rapidly and permanently deplete the myocardium of its oxygen stores. You've got to fill the tank first.
Moving on to Section 2. Classification of shock. Once you've addressed any hypovolemia, we have to categorize the initiating mechanism.
The most clinically applicable method breaks shock down into these 5 primary initiating mechanisms. We've got hemorrhagic or hypovolemic shock, cardiogenic shock from a failing pump, obstructive shock, think of a mechanical blockage like a tension pneumothorax, distributed shock, seen in sepsis or anaphylaxis, and endocrine shock. But keep in mind, patients rarely read the textbook, right? These states can, and very often do, profoundly overlap within the same patient.
Take a look at the distinct cardiovascular profiles we have here. Hypovolemic, cardiogenic, and obstructive shock all share a low cardiac output and a compensatory high systemic vascular resistance. But notice how distributive shock is entirely different. It features massive vascular dilatation and an abnormally high cardiac output. Now, this is really cool. Today, emerging AI algorithms are being trained to continuously analyze these exact hemodynamic variables in real time. This is actively helping clinicians instantly categorize complex mixed shock states right at the bedside.
Okay, Section 3, recognizing clinical features. Transitioning from theory to the actual bedside, we have to accurately interpret the physical signs of progressive decompensation.
You see, shock is a highly deceptive spectrum. In compensated shock, the body is smart. It sacrifices the peripheries to save the core. The patient might actually have a completely normal blood pressure, but their non-essential organs are suffocating just to keep the brain and heart alive. As further volume is lost, the patient slips into uncompensated shock. Those compensatory mechanisms overload, blood pressure drops, the patient becomes drowsy or even comatose, and urine output just stops entirely. Recognizing that highly deceptive compensated phase is absolutely critical.
Which brings us to a classic clinical trap. Let me ask you, is blood pressure a reliable early sign of shock? The short answer, absolutely not. Relying on a normal blood pressure reading to rule out shock is a very, very dangerous game.
Fit young adults and children can maintain a completely normal blood pressure through dramatic peripheral vasoconstriction and increases in stroke volume until they've lost 30 to 40% of their circulating blood volume. Let that sink in. By the time their blood pressure finally drops, they are literally on the brink of total collapse. Hypotension is a late-stage alarm. This is exactly where AI-driven early warning scores are revolutionizing our wards. By continuously analyzing subtle multi-parameter shifts like heart rate variability and respiratory patterns, AI can flag compensated shock hours before that catastrophic drop in blood pressure ever happens.
You really have to look beyond standard vital signs. For example, patients on beta blockers literally cannot mount a tachycardic response. And sometimes, penetrating trauma in the young actually causes a paradoxical bradycardia. Then you have distributive shock, where patients will actually have warm peripheries and a brisk capillary refill despite being in profound shock.
Finally, an elderly hypertensive patient reading a quote-unquote normal blood pressure of 120/80 might actually be deeply hypotensive relative to their baseline. The clinical picture is messy. This is exactly why synthesizing your patient history with advanced predictive monitoring is your best defense.
Section 4. Principles of Resuscitation. Recognizing shock is only half the battle. We now have to effectively monitor how they respond to us.
Because isolated blood pressure is so misleading, we have to look deeper. Central venous pressure, or CVP, should never be relied on as a single static number. You've got to assess it dynamically by watching the response to a rapid fluid challenge. We look at urine output, base deficit, and mixed venous oxygen saturation. Increasingly, we're using AI platforms that seamlessly integrate these dynamic changes with metabolic markers to project a patient's trajectory in real time, rather than just staring at static snapshots on a monitor.
Now, remember, lactic acid is generated by cells undergoing anaerobic respiration. The base deficit gives us a stark, quantitative look at the severity of this metabolic acidosis. Patients with a base deficit greater than 6 millimoles per liter face significantly higher morbidity and mortality. It tells you exactly how deeply the tissues are starving for oxygen, regardless of what the blood pressure cuff says.
So, the entire trajectory of your resuscitation splits right here at a fundamental question. Is the patient actively bleeding? In patients who aren't bleeding, your priority is normalizing end organ perfusion using fluids and targeted pressors. But if they are actively bleeding, meaning they are non-responders or just transient responders to a fluid challenge, the absolute priority abruptly shifts to achieving rapid hemostasis.
Which leads us to Section 5, Damage Control Resuscitation. This is where immense medical complexity meets intense human emotion, because standard fluid protocols will quite literally kill an actively bleeding patient.
In these cases, we must utilize damage control resuscitation, or DCR. You simply cannot correct shock while a patient is bleeding out. Repeated cycles of volume resuscitation with clear fluids will only exacerbate acute traumatic coagulopathy, hypothermia, and acidosis, which we know as the lethal triad. DCR relies on rapid control of the bleeding, allowing permissive hypotension, actively avoiding dilutional coagulopathy, and treating existing coagulation deficits to keep the patient from slipping into that irreversible triad.
Pouring clear fluids into a bleeding patient only dilutes whatever existing clotting factors they have left. Instead, we have to replace exactly what's being lost with a balanced 1-to-1-to-1 transfusion of red blood cells, fresh frozen plasma, and platelets, basically mimicking whole blood. Also, most bleeding patients become hyperfibrinolytic, so empirical administration of tranexamic acid, or TXA, is vital to stabilize those clots.
This damage control philosophy extends directly into the operating theater. You intervene strictly to stop the bleeding and prevent further injury so they can live to fight another day for definitive surgery. And as future surgeons, this is exactly where your communication skills are tested to the absolute limit. Imagine having to walk out to a waiting room to explain to a terrified family that you intentionally left their loved one's abdomen open and didn't fix everything. You need to empathetically, yet clearly, counsel them that this minimum intervention is a deliberate, life-saving strategy to let the patient's physiology recover. It's not a failure of the surgical team.
Even after the bleeding stops, you've got to be hyper-vigilant for occult hyperperfusion in the ICU. This is a highly deceptive state where a patient exhibits perfectly normal vital signs, but their tissues are still starving. If a patient spends more than 12 hours in this state, their mortality risk literally doubles or triples. This is the frontier where AI really excels right now. Machine learning algorithms in the ICU can continuously process mixed venous oxygen saturation and lactate clearance rates, alerting you to occult hyperperfusion long before the human eye could ever detect a trend on the monitor.
I want to leave you with this thought. If a patient's vital signs look flawless on the monitor, but their base deficit remains high, are they truly resuscitated? Well, no. In modern surgical practice, treating the surface numbers is no longer enough. You have to leverage every single tool, from advanced AI monitoring to your own finely tuned clinical intuition, to treat the profound cellular hypoxia hidden just beneath the surface. And above all else, you must remember that behind every dataset is a vulnerable patient whose family relies on your empathy just as much as your surgical skill. Thanks for joining me on this explainer. I hope you found it valuable.